It's time for DocTalk Radio, brought to you by Gilbert Hospital and Florence and Anthem Hospitals. I'm Dr. Ann Borik, board certified in internal medicine, and I'm here to keep you up to date on the latest information pertaining to your health and well-being. Welcome to DocTalk Radio. Joe, how are you today?
I'm good. How are you, Dr. Borik?
Good, good. We have a great show in store. We have a couple guys in the studio with us here today. DocTalk Radio is sponsored by Gilbert Hospital and Florence Hospital at Anthem. Welcome, Dr. Mike Funicello.
Thanks for having me back.
Chiropractor. Yes, we had a great show before, and you did so well. I wanted to have you back and continue the conversation.
Thanks.
And Nick Hunter is our physical therapist from the hospital. Nick, thank you.
Thank you. What a pleasure to be here with you guys today.
That's great. I'm really excited about today's show. Anybody out there listening, if you're interested in calling in, we're going to be talking about balance, posture, the importance of posture and how it relates to preserving health, decreasing headache and neck pain. Even high blood pressure has been associated with poor posture. We're going to talk about shoulder problems. We're going to talk a little bit about dizziness and vertigo. So we have a lot of stuff to cover today. I'd like to keep the calls really focused on physical therapy, chiropractic content. So that's really the theme for today's show. Let's get started. Dr. Funicello, I know we were talking a little bit about how you test for posture. Mm-hmm. Let's talk a little bit about posture. What is it, and how do you assess it?
Yeah, so in our office, what we're looking for really is how the posture is an overall assessment about how the structure of the body looks on the inside. Right. So when we assess for posture in our office, we use special posture apps on the iPad, and it gives a bit of good indication of how we can mark landmark points on the body. So It gives an idea of what's going on in the structure of the shoulders, the level, the head, the hips, the ankles, rotation, that sort of thing, from the front and also from the side. So when we get into that more posture, it's harder to describe, over a radio, but maybe people are watching, they can see. But right. There's certain things we're looking for from the front view, and then also things that we're looking for from the side view.
Like what? For example, leg length discrepancy or shoulder height, or
exactly.
When you're looking at somebody, what do you look
exactly.
for?
So that's a good point. So. And these are some of the things you can do at home. So people can do at home, check their kids or whatever, look in a mirror, they can kind of see where they're at. So it's a good kind of self-assessment tool. So, yeah, leg length would be something that you it shows up more in your hips, your pelvis, than you can see standing. Mm-hmm. We do check leg length, but that would be something they do more when they're laying face down on the table, because then that's when the musculature draws it up or the pelvis rotates, and you'll see that leg length there. But when someone's standing, it'll show up more in their hips. So if you have a shorter leg, and a lot of times, Nick probably can attest to this too, there's different ways. It could be a functional short leg, is what we say, and that's more of the musculature or the rotation of the pelvis, that sort of thing. And that's really, in our office anyway, you see that more, 90-95% of the time. 5% of the time people have a structural short leg. Maybe you guys would probably see more than me, but maybe post-surgical or something where you're seeing actual change in the length of the femur or the tibia or the bones, the structure.
Right.
But we see that, congenitally, from time to time too. It's just not as big. And then so the hips is one thing, the shoulder. So we're looking for a higher or lower shoulder. Then ears. So you can check your ears and see if those are tilted side to side, or if you see more of your face. If you're looking at somebody, it's hard if you're doing it on yourself, because you can't really turn your head and see yourself as easily. But you can look and see if you see more of someone's face or more of your child's face or that sort of thing, to get a sense of there's rotation on the axis around this part of your body, x-axis.
Okay, so really inspection, that, when in history and physical taking, in medical school, that's part of what we're trained to do, is to, watch somebody walk across the room. When I had my office, I would oftentimes ask people to take their shoes off, and I'd look at the sole of the shoe and see how it's worn. Are they supinating or pronating or, those kinds of things?
Yeah, definitely.
And so that's what people can maybe, take home. And you talked about an app.
Yeah,
It's amazing.
I know. There's an app for that.
They have an app for that.
An app for that.
Isn't that, that's awesome.
Yeah. It's really cool. It's a good tool. We used to be able to do it, more visually inspect, or, there's different systems where you'd have strings and you could kind of line it up and someone would stand in front of it. And, just like anything else, it's just technology improves, and now it's just easier to do that. So we can mark those points, and then that the program will analyze your posture and give you a better sense of, where there's some gravitational stresses that may be going on in your spine. So years ago, I can't pronounce his name, he's an Indian guy, Kapanjaji or something like that, but he said that every inch that your head is carried forward on your shoulders, of that neutral plane line, that adds another relative 10 pounds of weight that your structure of your spine has to support. So there's every inch that's forward, we see a lot of times, you probably do too, it's 2 inches forward or 2.5 or 3 inches forward, based on the structure. So that's another 10, 20, 30 pounds of weight that now your cervical spine or your upper back, your shoulders have to carry that weight, anatomically that's a lot of work, and it takes more muscle strain and everything else. So
and then the muscles go into spasm, and then people really end up with chronic neck pain, chronic headaches, even high blood pressure. We see that. Joe, do you have a question already?
I do. Ricky H. from Gilbert called in. He's 42. He said he's been to several chiropractors in his life, and he's always been told he's had one leg longer than the other. Sometimes it's the left leg, sometimes it's the right leg, so he's not 100% sure. And everyone he's talked to subsequently have said if they've gone to chiropractors, they've also had one longer leg. He says, is that a ploy to make money, or is that true?
That's a good question.
Yeah, it's a totally honest question. Yeah, I mean, it's definitely not a ploy to make money in my office. I can't speak for the other doctors he's seen, but it's really common to have something like that. I mean, it's just a really common situation to have. So maybe we see that a lot. But again, it could be a functional thing. It doesn't mean that it's stuck like that. Maybe in his case, he has an anatomically short leg, and it's not going to change by getting different care or rehab procedures. I don't know. I can't speak to that.
If it's structural, a lot of times you adapt. You adapt to it, and the other question is it really pathophysiologic? Is it causing pathology?
Right.
Because a lot of times, we had a breast cancer surgeon here a couple weeks ago, and it's not uncommon to have, anatomically one breast larger than the other. There's nothing you're going to do about that.
Right.
A lot of times the eye sometimes is, structured differently in terms of level, and so that's how we're born.
Right.
And I think maybe that's what he's referring to. So unless it's really causing problems, probably not a whole lot to do.
Does it really concern you? And one thing, every doctor is going to assess something a little bit differently, and while you may have sometimes one doctor say one leg's longer than the other, and another doctor say just the opposite, that can very well be the case with you depending on what's going on with your hips. Kind of like what Mike's talking about. Functionally, how does it relate? And hip rotation can be a big factor.
Right.
So that's where, again, going back to posture can really play a role in that leg length discrepancy.
I think really for us, balance has a lot to do with, posture, especially in the hospital. When we have patients in the hospital, and then if they're discharged to home, we want to make sure that they're structurally stable.
Absolutely.
That they're not going to go home and fall, God forbid, and break a hip or, something like that, or bump their head and have a bleed, or, Let's talk a little bit about balance, because that's important.
Absolutely. We see a lot of balance today, and everyone over the age of 55 needs to be incorporating some sort of balance exercise into a routine.
Right.
And it's really easy to do, a lot of fun, and takes very little equipment.
Okay.
Basic forms of balance is narrowing your base of support. And your base of support in this case are your feet.
Okay.
I like doing it with shoes off, kind of like what you alluded to earlier. It gives you a lot more sensation at the feet.
Mm-hmm.
There's 3 systems of balance in our body. The vestibular or inner ear system, vision plays a large part in our balance, and then our muscles and stretch sensors in our lower legs. And that's where taking our shoes off and waking up our feet plays a big part in improving our balance.
Very good.
So do you think that has something to do with those newer shoes too, that are more where your feet are actually touching the earth more? Do you think is that a big reason why they developed those shoes?
That is, and they're showing that a lot with the active population. They're responding better to that because they're gentler on their feet. When they're not in shoes with a lot of cushion, there's a lot of pounding, and that can wear on the legs, hips, back. I'm sure you see a lot of that. Without shoes or with a minimalist style approach where they have taken a lot of cushion, a lot of support, and just put in a zero profile or the same width of shoe from toe to heel, it's now even that out, and so balance is improving.
Right, so less is more.
Less is more.
Really,
and sometimes you see a lot less, and I find, because again, I kind of look at things from that neurological perspective of how it functions. But also just if you're not having that kind of wedge shape in your foot, now you've got less, biomechanically your joints are going to work how they're intended to work. Rather, you're not going to get as much impingement on the tibia fibula area and the knee joints, and then the hip it's not thrown off. The muscles are in their full length. They're not shortened and all that sort of stuff.
So for people at home watching, let's go through a little balance exercise. Can you do that?
Yeah, we can do that.
I mean, you're a physical therapist, so let's do a little physical therapy.
Put them to work.
Okay, all right, that sounds good.
The biggest thing is standing up.
Okay.
If you bring your feet and knees right together.
Okay.
And as upright with as good posture as you can muster, bring your shoulders back, and then just stand feet close together and stand there as best you can. And try and pay attention to how much sway, side to side, front to back, that you have. It seems pretty easy right now with our feet together.
Mm-hmm.
And now we want to make that a little more difficult. Once we're safe here, we can make that a little more difficult. And the quickest way to do that is to close your eyes. Safety is always a concern with home exercises, especially concerning balance, because we're not really challenging balance unless we're creating a fall-like environment.
That's
so
huge to
safety,
understand.
safety, safety. Find yourself either in a corner where you have two walls next to you so you can have that for support. Sometimes at a kitchen counter where you have your hands nice and safe. If you're in the kitchen, I always say put a chair behind you. So if you do start to fall, you're going to find a safe landing.
Don't do it around your glass coffee table.
Exactly.
Exactly.
That's a very good point. So feet together, close your eyes. The next step, we want to stagger our feet. It's hard to see that on the camera, but if your feet are close together this way, then we want to stagger, and we're going to do one foot halfway in front of the other, kind of right at the arch of our other foot. And then again, eyes open, go to eyes closed. The next progression is heel-toe, like a sobriety test. How well do you do heel-toe? And you're always doing this one foot in front of the other, and then you switch, other foot in front of the other. You always do things both sides, or as we call it in medicine, bilaterally, both sides. Eyes open, eyes closed, and then you can progress to a single leg. Can you lift one leg up, keeping the space between your legs appropriate without letting them touch, and then hover your hands over a counter or somewhere that's stable so that if you do start to fall, you have a safety net. And you can always do that again, eyes open, eyes closed. And then to add the third variable into balance, that's the vestibular system, we can throw in a head shake. And a head shake is as simple as tilting your eyes down about 30 degrees, or just like you're looking over the edge of your glasses, for those of you who have glasses. Find a stable object out in front of you. It can be anything that's sitting down. Keep your gaze or your vision stabilized on that object, and then shake your head. That's about 1 second per rotation while maintaining a gaze on that object. And you don't have to go very far. We're not looking over our shoulder. We're just going as far as about 15 degrees off of center, 15 to 20 degrees off of center.
Now, people that have vestibular problems, vertigo, is that shaking of the head a good thing to do?
It is. And that's where duration really comes into handy, or comes into play, rather, when we prescribe these exercises, is the dose for that duration is very short, because it can be very irritating to that vestibular system, such that we can become nauseated, or we can elicit a dizzy response where now we need to lay down for the rest of the day. So you want to be cautious with that, and 15 seconds with the head shake is plenty. As we develop a higher tolerance to that kind of time frame, we can then add in more time. But you do so gradually, guardedly.
And I think that's important for the listeners to hear, is that, even in balance, you want to do it gradually. You want to, make sure that you're comfortable in the posture that you're in, and then gradually move to the next posture, right?
The ideal standard is if you could stand on one leg with very little sway for 30 seconds, you're in great shape.
Perfect. That's a great tip. Okay.
I think the reason, too, what you're saying about the time is it takes time to get to that place. I mean, it's a learned pattern that your body, neurologically or whatever, other neuromuscular-wise, your body's learned how to adapt to that particular state of function in your musculature and your spine. So it's like learning a new language. You have to do that repetitively and frequently.
Exactly.
Until you've
Practice.
kind of burned in that new pattern into your body, and then it's something new.
Absolutely, very appropriate. And all these exercises, between 30 seconds to a minute, excluding the head shake, is appropriate. So if we're doing eyes open, eyes closed, 30 seconds to a minute is kind of where you want to do to sustain those postures, to enforce a change in our system. If we're doing a head shake, start at 15 seconds and see how you respond there.
Great. While we're standing, I know you brought an exercise band. I want you to explain what that is, and maybe you can show us some exercises.
Absolutely. Everyone listening, I'm sure, has known or gone through some sort of shoulder injury. And posture plays a big role in shoulder injury, because as we come forward with our shoulders with poor posture, that closes down this space in our shoulder called the subacromial space, which is the space where the arm bone of our shoulder comes in contact with the actual socket of our shoulder. And that relationship, if we want to kind of draw an analogy, is like a golf ball and a golf tee. Our arm bone's the golf ball. The golf tee is that socket. So there's a lot less surface area on that golf tee to the golf ball.
Ah, that's good. Okay.
And that allows us for the great mobility our shoulder's so known for. But with that comes an inherent instability. And so it now requires a lot more muscular stability to maintain health of that shoulder without injury. And I'm sure we've all heard the term rotator cuff. That's the series of muscles responsible for maintaining healthy muscle movement of that shoulder. And so this exercise band will allow us to help work on that.
Okay. The rotator cuff basically surrounds the entire shoulder area.
The golf ball. If
The
you want
golf
to think
ball.
of the golf ball, it's a series of 4 muscles. One comes on top. You have 2 that then come to the back side, and 1 comes into the front.
Okay.
And so rotation.
Nick, let me ask you, how do you assess to see even if it is a rotator cuff injury? Are there different things that we can do?
There is, and the shoulder's very dynamic, and so
Okay.
I don't want to paint the picture that it's limited to the rotator cuff because it's not.
Right.
But very commonly, rotator cuff at some point is going to be addressed, whether you're recovering or assessing any kind of shoulder injury. And quite simply put, any kind of shoulder test, if raising your arm is painful and difficult to sustain, there's some sort of damage to that rotator cuff that needs to be addressed.
So when you say sustain, if I were to push this down and you
Yeah.
couldn't hold that,
If weakness is a limiting factor, then that's rotator cuff. If it's pain also eventually leads to weakness because of the swelling.
okay. Very
And so
good.
out to the side's a good one. Even a better one to get real specific with some of the rotator cuff muscles is if you can hold your hand up kind of in this middle plane, if we've got a front and a side right in the middle, and then turn our thumb down like we're emptying a can of soda. And if that's difficult to maintain or painful, that's a sign of rotator cuff injury.
So how I would do that would be to hold this bottle of water, and if I couldn't do that,
And maintain that posturing.
then that suggests that there's an anterior rotator cuff injury. Very good. Okay.
And so with the exercise band, these are easy to come by. Any physical therapy clinic is going to have some sort of band, and whether they sell it or not is up to that individual clinic. Easy to do. You anchor it at home in a door. Just close it on the band, and then we're dealing with rotation. And the most specific motion with this is keeping the elbow tight to our side and keeping it hinging like a door. Sometimes we get lazy, we start extending the elbow or straightening the elbow straight down, and that's a sign of too much resistance or too much injury to the shoulder, where we may need to modify the exercise. The other form of compensation is we raise our elbow off of our side. And so one way to cue ourselves to not let that happen is to put a small towel roll or pillow under our arm right here so that we can kind of squeeze that, maintain it there as we do the rotation. And so rotating out away from our body is one exercise, then flipping around and rotating toward our belly button is another exercise, and those are good ones for the actual rotation of the rotator cuff.
That's very good. That's very good. Dr. Mike, anything that you want to add to the rotator cuff of the shoulder?
Well, I just seeing you when you're doing those exercises, I just think of my mind always goes to how these things develop. So I always look to, because that's what I really try to help people change is their underlying reason why they got that or how it came on. And so I've seen you do that, and I'm just thinking that's a lot of times, because I see kids and stuff too. So whether they're playing sports, especially with the rotator cuff, it's so important with kids. They're learning how to pitch or throw too early, and they're trying to throw curveballs and different pitches that they're not supposed to throw until they're fully developed. And also when you're talking about you can see when you get lazier and you get fatigued and you do that, and that's how you get injury a lot of times is you're doing those exercises, whether it's too high of a weight or pushing those last reps out or whatever, and that's when you're fatigued or your form isn't correct, and that's how you injure yourself. Because like he's saying, those rotator cuff muscles, they're really stabilizer muscles. They're not really for strength or power. They're to hold your joint in place, while the other larger muscle groups, like those big lat muscles like you use for rowing and things, they can work because you have a stable shoulder. If your shoulder is unstable, you're not going to be able to use those larger muscle groups. So and when you're getting lazy or fatigued, and there's not as much stability there, and you start to use those other larger muscles, you're a lot more prone to injury then, because you're overloading those smaller muscle groups that aren't designed to hold that
That's a
huge load.
great comment. Let's have a seat, because I know we have a few things coming in here.
We do. We've got a question from Tony here that says, My back has a hump at the top by my neck. I've always been told to stand up straight, but I seem to lean forward. Everyone says I have poor posture in my family. What can I do? It hurts to try to stand straight up. I also have naturally large breasts, and sometimes I feel like they make me lean forward.
So that's a real problem. I mean, if you're talking about an anatomical structure, your body has, how do you deal with that? So a lot of times in my office, I mean, again, I'm looking to the, what's going on in their body, what's causing their body to be pulled forward. Definitely that could be one contributing factor, but I really think that, we're designed in such a way that our bodies can adapt very well to what we're given from birth, so we wouldn't have something if it was going to cause a problem that we couldn't adapt to. But it could cause, changes in the upper back, a humping like that. A lot of times we see that coincides with other things that are going on, with, a buildup of that muscular tension like we talked about, from the head being carried forward or whatever it is that leads to that. And that can just contribute to, having larger breasts or other things that are having that happen, kind of, we call it comorbid kind of things, but happening together at the same time in our body. It doesn't have to be just one thing. It could be several factors going on that lead to that.
Right. From a physical standpoint, what would you recommend? Is there a certain exercise to help
Absolutely.
maybe strengthen that?
And a lot of these are anti-gravity type exercises that we look at doing. In this particular case, where we have kind of this forward progression of our shoulders and chest, and then having to with the rolled shoulders and then forward head, where we're kind of cocked down, and having to look back up, that forming that what we call the dowager's hump over that cervical and thoracic spine area. We put you down on your stomach and have you do just the opposite. So now you're on your stomach, face down, hands are in a W position, which is kind of this way, and we have you arch up. Roll your shoulders back so your shoulder blades are now squeezing that thoracic spine, and then you also do a chin tuck, which is chin to neck and not chin to chest. So it comes straight back, kind of like a chicken. Bring it straight back, and then we hold that position 5 seconds. Again, postural muscles are endurance muscles. These have to be able to maintain these postures all day long. They're our workhorses.
Right.
And so we have to train in that specific pattern. And so 5-second holds, these isometric, longer holds, are kind of what we want to go for. And then we progress from there. So we go longer holds, we incorporate weights, and go from there.
Right, but just that much, I think, is enough to answer that question.
Can you get rid of the hump?
I haven't seen it. I haven't seen it getting rid of. I see it a lot in practice, but as far as
You've seen it happen, though.
I haven't seen it.
No, I mean, have
been
you
removed.
seen a hump go
All the
away
time.
on people? Oh, all the time.
Going away? No, I don't see it going away, but I see pain going away. Dysfunction.
Oh, there's pain associated with
dysfunction
gotcha.
going away, but the actual formation of that hump, I have not seen it go away.
Sometimes when people lose weight, that may help. But for the most part, I think it's a structural thing that functionally we can make better. You can feel better, but structurally, I think that hump is going to be there.
Right.
Mm-hmm.
I have seen that change, actually. I have seen change in humps and things when the structure, if the structure changes, then
Right.
it doesn't need to be there. But I think it's like what you're saying. It's this patterning that gets set there. So if you don't change why the body's doing that, you can alleviate some pain, you can help with some function, but what are you doing to really change why it's getting to that place?
Exactly.
Like we talked about once before, and we just talked about if you're constantly dictating and you're doing some behavior over and over again the same way, and your body starts to adapt to that, so it starts to get changes in your curve, like you're saying, the rounding, the forward, and the head. It's adapting to the behavior that you're having. So if you don't change, how that is showing up in your body, the structure will start to change. So you'll start to get arthritic changes in the structure of the spine, and once that starts to develop, and you get that fusion or whatever, then that's an irreversible process. But up until that point, that's why we emphasize work with kids and stuff, and like you're saying with the shoulder, you don't want them to get that bad habit of throwing a certain way, or because you get into that pattern of doing that over and over again. But
Very good.
That's true.
We have a question.
Got a question, Sarah from Mesa. Looks like we have a lot of locals today.
Oh, good.
Sarah from Mesa says, I've been prescribed custom orthotics from my chiropractor. I wear them diligently every day. They're very expensive and my insurance does not cover them. Can I just go to the Walmart and get the ones from the machine that they have inside? Are those as effective?
yeah, I don't prescribe orthotics in my office, so I'm not really an expert in the orthotic area. But so I don't know how the ones at Walmart work,
Right.
or the ones that are prescribed. They're usually definitely better than what you can just go run out and buy at Walgreens or Walmart. But I don't do it in my office, so I can't really speak directly to the quality of those.
I know that we had a podiatrist on the show, and that question came up, and his response was that yes, you can go to the local Walmart or Walgreens. It's a great place to start. See how that works, and then eventually you gradually, depending on how you feel. Some people don't need custom orthotics.
Right.
What they have is sometimes just really all you need.
Right, and that's one thing that we see a lot in our practice too with physical therapy is to what end do I wear these? And obviously we hope to be able to bring people back to independence so they're not having to do that continually or renew those orthotics. And orthotics themselves are kind of under a lot of research because are they showing the change that they're purported to do? And,
right.
And we just haven't seen a great deal of response from that yet. So the best way to do it is to go to Walmart, try it out. Is it as effective for you as a patient as those custom orthotics?
Right.
Or even like we were talking about before, like you were saying about the shoes, the different, maybe that's what's really causing your issue. You don't need another insert in your shoe. What you need is take the inserts out, go
Maybe
back
less,
to a more basic, minimalist type of shoe where your anatomy is actually more grounded in how we're supposed to walk on the earth. Maybe you could, I don't know if prescribe something like walking in sand or dirt, if that's around, here
well,
it's
we actually
in the desert. But
we actually do that in clinic. We'll have, they're called foot intrinsic muscles, the muscles between your toes and your heel. All the muscles that are involved in the more active structure of the foot can be rehabilitated. They can be strengthened, and kind of like what Mike's talking about here with walking in sand or picking up objects with their toes to improve not only dexterity but also strength to those intrinsics. They are effective in restoring some foot health. And in fact, a lot of shoe companies are under legal scrutiny because of their purported claims of fewer injuries and better performance. Puma is the latest to be under some legal scrutiny. Skechers with their rolling shoes, they're under litigation currently because of these claims that are not coming to fruition.
Right. That's interesting.
Mary Frances, Springfield, Missouri, says, I have scoliosis since I was a child. Have never had it treated. Now my daughter is 13, and she's having severe back pains a lot. Is it genetic, and what should I do?
It's a good question.
I'll defer to Mike on that one.
So that's a question that we get a lot, and we also get scrutinized a lot as chiropractors who say, you can fix scoliosis. So again, I just always go back to why is this scoliosis developing? And so to her question about whether that's genetic or is functional, we do see a lot of times again that functional aspect because there's you have your structure of your spine, your bones, you have muscles pulling on those bones. So in lieu of a change in the structure, so each vertebrae is kind of shaped like a box, and you can be born with a vertebrae that's shaped like a triangle, and that is going to cause a wedge shape. So you may have a structural change in your spine that will lead to predispose you to have a curve in your spine. But barring that, if your spine, the structure of your spine is healthy, squares and boxes sort of thing, keep it simple, then the muscles around it, if they're balanced and they're functioning, equally bilaterally, the same amount of stress and pulling on each side, where there's no hyperspasm or hypertonicity in the muscles around your spine. Again, like Nick was saying, those core spinal muscles are really for endurance. They're they're posturally supporting muscles. If those are balanced equally side to side, then you're really not going to see an imbalance in the muscular pulling on either side. It leads to a lot of these lateral curvatures of the spine, different than we were talking about the head carried forward. Now we're talking about a side bending curve, which is scoliosis. And so we, I think that there is room to create a change if we get, change that earlier on. But like she's saying, Mary Frances, I think that was her name, at a certain age, you've got this progressive degenerative change that's taken place. You can work functionally to reduce some pain and that sort of thing, but you're not really going to necessarily change the structure of those spinal bones. So it would be something to definitely check out early with the daughter. And we assess that through the degree, the curve, and all that sort of thing to see where they're at, because they can progress during puberty and that sort of thing. So
yeah, I think you really said it right just then, because each individual and their health requires an assessment, like you've been talking about. I wish we could give some of these great questions the silver bullet, the golden ticket as far as what's right for you, and it comes down to the fact that we, as healthcare professionals, we assess, we evaluate, and try and find what is it for you that's causing this, or that, and then we can help.
Right. There are some genetic problems that predispose people to scoliosis and those kinds of things. So in answer to that, yes, there are. I think it's a little bit beyond the conversation here today, but it is something that you can talk to your doctor about for sure.
Absolutely.
Is it genetic then?
There are some genetic, people with spina bifida and different, genetic
Gotcha.
inherited conditions that scoliosis is part of the syndrome. But scoliosis in and of itself, I don't know, isolated, I don't know if that in and of itself is genetic.
Right.
So that's a good question that I just don't have the answer to.
I mean, a big percentage of what gets diagnosed as scoliosis is called idiopathic scoliosis, which is a big word meaning we don't know why you have scoliosis.
Exactly.
And so whether that's genetic or not, it's just the term that's given to that type of scoliosis,
Right.
whereas the other ones we have a more direct name for.
Since you mentioned the rolling shoes, we had Kelly from Little Rock, Arkansas, and Tony from Florence, both with the exact same question. Should I get rid of these immediately?
From my professional opinion, I would say yes. Mostly because they're a fall risk. They alter your balance in such a way that you...
We're talking about the ones with the front that go up like this?
They kind of have a rocker bottom kind of design.
I have those too.
It's not that the rocker bottom's
Yeah.
a problem. It's more of just where it puts your foot. It confuses your foot as to where you are in space, as to where your balance are. And so I've had several patients who have fallen or rolled an ankle because there's actually quite a bit of change in lift from the floor. And so the heel to the floor is now different, and that gives a much greater lever for ankle rolling, for twisting your ankle, stepping off a curve, or even stepping on a rock. It can be as little as a rock that now is given enough momentum to throw your ankle. And so I'm not a fan of those shoes. I'm a fan of what they were trying to do. They were trying to help patients, or people rather, get more healthy, get more active, and I'm a huge fan of that. I wish it was done a little differently.
Right. And we need to be careful. We need to be careful not to introduce things that are going to bring injury to the body, to the foot, to the leg, to the hips, to the back, to the neck.
Right.
That's one of those things where the theory, creates some instability or whatever.
Right.
like a Swedish ball or something. It's a good thing, but then you build it into a shoe and it becomes a bad thing, maybe. Or it's
Right.
like the theory of why you're
Yeah.
doing that might be a really great idea.
Right.
That
static,
kind of
but when you bring it
neurologic
into a dynamic movement pattern, it could be dangerous. Yeah, I know there's some other questions coming in. I want to talk a little bit about proprioception, because I think proprioception, really speaks to balance.
Absolutely.
And when we assess somebody, well, let's first of all define proprioception. Do you want to speak to that?
Quite simply, it's your body's awareness of where you are in space without
Absolutely.
having to look at it.
Right. And so a lot of times what we'll do is when I assess a patient, I'll have them maybe close their eyes or look away, and I'll take their big toe and I'll move it up or down. And I'll say, is it up or down? And that's a way to see if they really are in tune with the position of that toe in space. From a physical therapy standpoint, where does proprioception come into play?
Absolutely. We do that test quite often, actually, especially when we are as a component of balance. Patients with diabetes and neuropathies in their feet, where now those nerves, those sensory nerves have been compromised. They're no longer as aware. And absolutely, that's where we try and bring in different sensations: wet, cold, hard, soft. We do spongy, spiky, all just different sensations for them to grab, grasp, feel, roll over. And then all these exercises we'll do with eyes closed. Again, going back to eyes closed, because that sensitizes, that forces your proprioceptive sensors in your feet to be more aware, turns them up.
Right. Very good. From a chiropractic standpoint, anything?
Yeah, similar. I mean, we do the same kind of test, again, to go back to that assessment thing. When someone comes in, if they're having some kind of a body awareness issues, in which a lot of physical stuff that we have going on in our body, health-wise or well-being-wise, is because we just don't have a clear body awareness. We're not self-aware of what our body's really up to or what it's doing. So we don't know how to change anything to feel better and be more well. But just like Nick was saying, so we do tests, with the position of the toes, or even like what you were doing before. I'll have people stand and check their feet together, and then have them close their eyes and put their feet in front of each other to assess what's happening, because it's why, their balance, again, it's that sensory input that's a, neurologic feedback to your brain. So you can do that with your eyes open because it's like not really cheating. I mean, our bodies have that, but, you can see more easily where you are, and you close your eyes, and now you don't know. So you have to rely on what your body is telling you, and that happens through your nervous system.
Good. We have another question, Joe.
We've got 3 questions. First one, Carmel Bay. I know there are infinite core exercises. Is there any that are specific to keep you in good alignment?
That's a really open question. And as far as specifics, it would really depend on the patient. But there's a lot of great core exercises that don't involve crunching, which to some people is mind-blowing. But if we go back again to the understanding that our core muscles are postural endurance muscles, so they're not always dynamic. Now they can be, and we can exercise them in that capacity. But when we want postural and core stabilization, we're thinking isometric. We're thinking hold. So it's not necessarily going through a repetition of flexion and extension, but now we're thinking, how long can I hold this position? How long can I hold this exercise? In order
like a plank?
To get a plank. That's where you're laid down on your elbows and your toes, and you're holding a straight spine, almost like you're a board, a plank. You can do that on your elbows, do it on your hands, and then there's numerous variations that you can do on your side. You can stack your feet, all kinds of fun stuff.
So for the listener, just to visualize this, get into a position as if you're going to do a push-up, right? On the floor. With your face down.
Face down.
And then basically you prop yourself up so that you're holding yourself on your forearm and elbow, right? And you just hold that for, start out with 10 seconds and gradually go up to 30 seconds and maybe a minute. That's probably one of the best that I personally use just for core strengthening and stabilization.
Absolutely.
Now, for some of the seniors out there that are listening, I'm wondering, you can probably start a plank-like exercise standing maybe up against the wall.
Countertop, wall.
Right.
You can even go on the floor, but do it on your knees instead of your feet.
Right. And I think that's probably a really good core exercise to start with.
And that's great for the front part. And then you can do similar things for the back. Bridging is a great exercise where you're on your back with your knees bent up and your feet kind of near your rear, and then you bridge up. You form a bridge. You push down through your feet and your shoulders. You arch your back and your hips, and so you come up into a straight posture there, and you can perform a hold there as well.
Let me ask you, you mentioned isometric. People that maybe are in a wheelchair, maybe they've had a stroke or they're, elderly and they really don't get along, there's not a whole lot of mobility. Are there different isometric exercises that you can recommend, just, tightening the muscle and then releasing it, like a relaxation? Yeah.
Absolutely. There's really a lot, and depending on your mobility, anything can be what termed an exercise. And even if you're in a wheelchair and you even got just one side or both arms that are strong, pushing down through your elbows and trying to elevate your hips off of the seat, and then holding that posture as best you can. Even if you're seated and you've got pretty good leg strength or decent enough leg strength, you can brace your arms on the chair and then raise your legs up for a hip flexor and core strength. And just raising your legs with your knees bent is a good form. And as far as the dose, we're always talking in forms of seconds, 5, 10, 20, whatever seconds. And if you can do it maximally without causing pain or problems, that's what's going to give you the best result.
That's good. That's very good.
We've got Mel from Melbourne. His chiropractor has told him to get gel inserts for his shoes. He has gotten them and wants to know, are they for comfort, or is there actually a medical purpose for these things?
I would say that they're probably for comfort, because they're not really providing you any stability, really. It's not really a functional kind of platform.
Because he said they kind of squish his foot in some of his shoes, and he doesn't like them.
Yeah, I don't know why. I really can't answer. I can't speak for his chiropractor, but I would say it sounds to me more like it's for comfort, and so I wouldn't really know why he would be prescribing those, but I'm not sure. So I mean, without knowing what his thought process is. I couldn't say why he prescribed those, but yeah. So I really don't know the orthotic thing. Sorry again.
Yeah, sometimes an increased amount of cushion, like the gel insert, can be because of maybe you have a heel spur on your, in your foot, on your heel. Maybe you've got some plantar fasciitis that may, in his mind, be benefited by an additional form of
Yeah,
cushion.
Good point.
Would be the only things I can think of.
Peggy-Lynn out of Tucson. Can you recommend a pillow and mattress? I need to purchase new ones, and I'm in the market. Air, gel, etc. There's so many out there to choose from.
There are. And I get this question a lot, and I don't have any great response to that because I feel like there's such personal decisions as far as, for you, where are you most comfortable? And for some people it's a firmer mattress. For others it's a softer mattress. For me, I try and say, let's try and get you in a position in a mattress that is most comfortable. And for me, that's side lying with a pillow between your knees and your upper arm.
Yeah, I think we have a really similar philosophy about that, because this came up last time when I was here too, and I kind of apologized the same way to the person, because I'd love to be able to say you gotta get this one because it's the best one, but it's really just whatever supports you. And going back to what we were talking about with posture, it's whatever supports you in that neutral posture position, because you're there for hopefully 8 hours, could be less, but like Nick's saying, on your side. So if you sleep on your side, you want your head to be cradled, so if that pillow needs to support you so your head doesn't drop towards the bed, or prop you up so much that you've got an angle in your spine. So you want your nose, you want it to be in line with your spine, just like you would be standing. And the same thing on the back. You want to have it support your spine, support your body, so that you can lay comfortably, so you can actually rest and go to sleep. And we talked a little bit before last time about the gel versus foam or whatever. And I find that it's more of a comfort thing. So if that bed tends to feel hot or heat up, some of those foams get warm, then that's an uncomfortable bed for people, just because they get too hot, especially here, when it's
Right.
Yeah.
triple digits in the
Anything
summer.
that you would avoid, I'm just thinking about if, we don't, there's really not a recommendation, but for any specific, for example, low back pain or problems, anything to avoid, can you think of?
That's a good question, and it would depend on pathology
Right.
or disease or problem that you may have. And for me, I've found less often that a softer bed is beneficial. I've found that more moderate to firm mattresses have been more beneficial for those with low back pain.
Okay.
And so I would, if you really like a soft mattress, maybe try in the showroom something a little firmer and just see how that goes. But over time, I've seen soft mattresses only get softer, and then that tends to wear on people.
Right. That's good. That's good advice. Anything else, Joe? Okay.
We're up to date.
Carpal tunnel. Carpal tunnel is something that we were talking about, the neck and the upper back and posture and all of that. And a lot of times people don't realize that carpal tunnel can stem from back here in the neck. Do you want to speak to that a little bit? Maybe define carpal tunnel. We can talk about how it's treated.
Absolutely.
Because I think it's pretty prevalent.
It is, and I think it's often misunderstood a little bit as far as what the patient is experiencing, because carpal tunnel is a closing down of this space right on the front part of our wrist that affects our nerve. And that nerve is the median nerve that comes down and comes into the thumb and these two forefingers. And they get burning pain, sensation, loss of grip strength, and then that pain can also come up into the forearm as well. And so that nerve can get pinched in several areas. It can be right here at the wrist. It can be a little higher up where we have some of these stronger muscles that deal with grip strength, where this nerve actually splits and forms into two different nerves. It can also be up in the arm and the neck. So, Mike, if you want to talk about how it affects the neck.
Yeah, I mean, so that's the area that, of course, I'm hyper focused as a chiropractor. I always look to the spine to address that. And but yeah, I mean, it's just like you described the anatomy perfect. I think sometimes what people come in with is their whole hand is tingling, or both of their hands are tingling or numb, and they say I have
Glove-like
carpal tunnel.
sensation,
And it's like, I don't, whether they were on the internet or, a friend had it, and so they think they have carpal tunnel. That's not necessarily carpal tunnel, just because you have altered sensation in your hands and fingers. I mean, carpal tunnel is a specific thing, like Nick's saying, specific fingers from a certain nerve that's affected, and where that comes. So I think, going back to the whole assessment thing, I think a lot of times, when you hear carpal tunnel, I mean, our minds go immediately to carpal tunnel, but when someone says that, they might not really be describing carpal tunnel. So you have to really say, well, let's see what is really happening and assess and see, is it happening from your wrist, or is it something that's happening in your neck? Because we can do all kinds of stuff to your wrist, surgeries and everything else, but if it's something that's stemming from your neck or you're somewhere up, upper in your arm or wherever else, you're just not going to be addressing the cause, and then you're going to be right back where you were,
Right.
with a scar to show.
Some of
Souvenir.
the assessment techniques that we do is just to tap on the area where the median nerve is.
Right.
And by tapping on that, it's called the Tinel sign, and it really elicits a shock, that goes all the way down into the
Yep.
to the hand.
Kind of a shooting sensation.
We see it very commonly in diabetics. So that's something just to kind of keep in mind, people that are that are listening. Some of the things that I've done, and maybe I'd be interested to hear what you think, but from some studies looking at B12, B6, B complex, particularly vitamin B6 has been found to help regenerate the nerve, the casing around the nerve, and so we use it for compressive neuropathies such as carpal tunnel. And I don't know if you can speak to that in your practice or not, but I think people find that that's pretty helpful.
Yeah, I think there's a lot of new things happening with treatment for diabetic patients with neuropathy, because it used to be, that was like the end. It was,
Right.
You're progressing further and further. It just
that
showed
phase.
signs of a problem. The kidney issues and ulcers and that sort of thing. So I think that addressing it from that way, I don't do necessarily that
Nutritional
I would like
counseling.
I said,
Okay.
I would refer out to that, whether it's a their
Very
medical
good.
doc, primary care doc, or naturopath, or somebody that addresses that more specifically that way. But yeah, I've
Good.
heard the same thing in B12.
Good. Good.
Chris from Chattanooga says, is there a non-invasive surgery or treatment for carpal tunnel?
Lots, and that's where the assessment from a trained professional would really come in handy as to what exactly is going on. I see a lot of patients that have had the carpal tunnel release surgery, and it'll be effective for a little while, and then it comes back, and usually it's within 5 years, unfortunately. It depends, but again, it goes back to the cause, and that's, Mike's really hit this pretty effectively, I feel, is what is going on? What is the cause of why you're having these symptoms? And that needs to be addressed, and that's where the evaluation and the assessment come in handy.
We always recommend conservative treatment modalities first. Surgery is always the last thing that we want to recommend when it comes to, this type of surgery. Ice, anti-inflammatories, immobilizing it with a brace, particularly at night, taking supplements, such as B complex, vitamin B6, B12.
Can you overtake those?
Actually, no. Vitamin B is a water-soluble vitamin, so it doesn't really store in the fat in the body. So if you take too much, you basically just excrete it out. So that's not really a major
Good.
problem. But those are the things that we really would recommend. And ergonomics. If you're working on a computer, make sure that you adjust your workspace, because that kind of a situation is going to put extra stress in that.
And I have to throw in my 2 cents. I have carpal tunnel pretty bad in my right hand, and I get to the point I didn't think I could even type anymore. I was going, oh my God. Just getting these ergonomic keyboards has made, and this little gel thing has made an incredible difference. I mean, all the difference in the world. My hands would be, within 60 seconds, completely numb right here, going up.
Yep.
And now I can type without that happening. So
people listening, take note of that. That's very, very important to do.
And the kind of posturing they're suggesting that's causing that pain on that nerve is the extended wrist posture, where if our hand's flat on the table and we lift our hand off of the table, that kind of posturing is what's putting strain on that carpal tunnel, on that nerve. And so anything we can do to elevate that wrist and keep that hand as flat as possible, or as neutral, we call that neutral, as possible, will relieve a lot of those symptoms.
Right. That's why we recommend a brace when you go to sleep, is to keep it in that neutral posture, and that really tends to help a lot of people.
And I think a big part too is actually changing behavior.
Yeah.
It's like if you just do the same thing over and over, even if you have, like Nick's saying, you see these people that have had the release surgery and they're back with it, they're like,
Yeah,
well,
they didn't.
how did you change your lifestyle? Oh, well, I didn't have to. I had the surgery. Well, it's like, well, that's why, you might have to change the way you type or play guitar or piano or whenever you're doing it. You don't want to take someone's lifestyle away. But you have to address those lifestyle factors that contribute to why people are developing these things in the first place, or what's contributing.
my mother's had that surgery 3 times.
Yeah.
Really?
Wow.
Let's see. Question out there from a chatter. Can you have carpal tunnel without the pain? Just numbness of the lateral aspect of the thumb? Actually, it's a kind of a double question. Do you want to answer that first?
You can, yes.
Okay.
Yeah, absolutely you can. You don't have to have, the severe pain. It can be just the paresthesia, which is the numbness. And then in weakness, sometimes people just have a weakness that may not be associated with either pain or tingling or, so yes, any one of those three can be part of the triad.
Oh, you answered her second part. Perfect.
Which is what?
If the nerve is compressed, is there a way to release it without surgery? So,
Absolutely. Yeah. Surgery. Let's talk about surgery. We only have a few minutes left. This hour really has gone. And before we close, I want to get a little bit of information about your practices so people
Sure.
listening, if they're interested, they can give you a call. Surgery. What do you recommend? We oftentimes recommend physical therapy. I personally, in the hospital, will recommend a physical therapy consult for our post-op patients, for our hips, shoulders. Talk a little bit about your approach to a post-op patient.
Post-op it's a lot of fun to get people who are out of surgery because they want to get better. They're from rock bottom, and now we get to help them and see a lot of change. And so professionally, it's a great patient to be in. As far as what you can do, you always want to listen to the instructions from your doctor, and it depends on what operation was performed, what procedure they did, as far as what you can and can't do. And they're pretty good at communicating the don't do these. So then the question is, what can I do? And beyond what you should not do and what's outlined clearly, you can do. And after surgery, pain is a beautiful guide, because if it hurts to do this, hold on a little bit. Just wait a little bit longer before you start doing that. Now, that's not always the case, especially when we talk about total joint replacement. That can be in the knee or the hip, because pain is now a part of rehab, and that's where physical therapy gets, PT, we get pain and torture, physical terrorists, we get these kind of names because that's what we get to do. We get to help you fight through some of that discomfort to improve mobility to those joints.
Right. So what I'm hearing you say is people that have, for example, a hip replacement, if they feel pain, that may not necessarily be a bad thing. You want to work through that and, grin and bear it, basically.
Right.
Okay.
Listen to what you should not do. Be very, very diligent in adhering to those guidelines. And then beyond that, be aware that it may hurt to do those things because you just had a major operation.
Right.
But you'll need to get to
But
that
in the
point.
long run, I think that's going to be, it's going to prevent blood clots. It's going to help decrease the incidence of pneumonia by getting up and moving and getting oxygen moving in the body, right?
Yes.
Balance, all of those things, healing.
One of the worst things to do if you're recovering from surgery is lay there. That's where you get dangerous. Even if it's just pumping your hands, pumping your elbows, pumping your ankles, just some form of movement. It doesn't even have to be that you get up, but you have to move, is going to be extremely beneficial in preventing some of these concerns you have anytime you're after a surgery, you're post-op.
Very good. Okay.
Janet from Mesa just wanted to say she's a regular watching DocTalk radio. Actually had an issue, had to go to the hospital, and took the drive to Florence Hospital after watching the show many times. And she wants to say that a fantastic hospital, huge difference in the time it took and the personal care. Thanks, DocTalk and Florence Hospital.
Very good.
Right.
Wow, that's great.
Right on.
We're getting busy. The hospital is, I think we're going to be coming into now the fall and the winter, and I think the busy season, and so we're ready. We're there. If anybody, with door to dock in 31 minutes. Actually, I think we're less than 8 minutes,
That's
and that makes a
fantastic.
difference. Just getting back. If somebody comes in with pain or a joint, you don't want to sit in the waiting room and not move. You want to get in. We don't want to seat you. We want to treat you. We got to get to what's going on so that we can fix the problem, so that you can get on the road to recovery.
And I can tell you that is true. When I broke my wrist, I drove by 2 other hospitals that were closer to get to Gilbert Hospital because I knew by the time I'm done filling out my paperwork, I'll be back in a room, or it'll be very soon after. And it was within about 5 minutes after I was done with my paperwork. So
I remember that. How are you doing?
Great. I'm back to doing everything I love to do.
Good.
It's fun.
Fantastic. Tell us a little bit about your practice, how people can get a hold of you. We'll start with you, Nick, and then Dr. Funicello will get your information.
Great. So I'm very nearby here in Mesa. I'm off of Power and Baseline in a company called Ideal Physical Therapy. I'm now the partner therapist at that location, and we're right behind Tropical Smoothie Cafe on the west corner of Power and Baseline. And actually this Saturday, my other therapist in there, Doug Schrift, is going to be doing a balance seminar from 10 to 11 at that Power and Baseline location. You can find us on idealrehab.com. You can also search Ideal Physical Therapy on Facebook and get our locations to the Mesa Clinic on Power and Baseline. And he's going to be discussing all things relating to balance progression, and then balance exercises. He's a geriatric certified specialist, which plays into balance very well.
Wow, that's great. Dr. Funicello.
I'm just up the street from Nick. Actually, I'm on the south side of Baseline, just east of Lindsay. Infinite Healing Arts Center is the name of my office. You can again search Facebook Infinite Healing Arts or infinitehealingarts.com. My phone number is 480-558-1560.
Very good.
That's
Very
in
good.
Gilbert officially.
You know, it's great to have people like you on the show, you know, because I think this really lends to what the public oftentimes wants to hear. You know, in terms of, you know, it's great to have a surgeon, and it's great to have, next week, for example, we're going to have somebody that is a very high-powered pulmonology specialist who deals with lung transplantation.
Wow.
It's going to be a great show. But I think it's important to bring folks like you who really could answer questions that are everyday kind of questions, and how to preserve health and wellness and you know, really keep the body well.
And we had several people saying, thank you so much, great guests. I mean, all kinds of comments like that regarding the guests and the show. So
Good. You know, people listening, now we're getting a little following, which is really neat. Please don't hesitate to call in, email in, let us know what you want to hear. You know, if there's any guest or any specific specialty as it relates to medicine and DocTalk, I'd love to know, you know, what's on your mind. We have a lot of different people, you know, in the future set up. We have a psychiatrist that's going to be on the show talking about anxiety disorders, pediatrics, cancer specialist.
Wow,
you know,
what a great show.
I'm going to get a veterinary.
That'll be fun.
I haven't finally, you know, gotten that person in yet, but I really want to have a vet on the show so that we can talk about the health and wellness of our animals, of
Sure.
our pets. So
Right.
I'd love to hear a little bit more out there.
One thing I've really enjoyed in following the show with the DocTalk is the approach to overall wellness. I mean, whenever I think of Dr. Ann Borik, I think wellness, fitness, health, all of those things really embody what she's all about, and that's why I think she's a great resource in bringing in varying difference of professions and specialties, because I get a lot of patients who say, oh, your physical therapy, I didn't know you treat balance or vestibular problems. I didn't know that you do this. And I'm sure Mike gets that a lot in chiropractics. There's just so much that we can do to help out that I think people don't quite know.
Right. That's really very, very
I
important.
just really echo what he's saying. I really appreciate the fact that that's your focus, you know, that sort of thing. And I've heard you talk about, you know, how important breath is and things like that. I mean, that's just not what you hear from your typical,
Right.
you know,
Yeah.
go in 7-minute office visit at the doctor's office. I mean, you're just not going to get that kind of,
Right.
you know, attention to that real thing that makes a real difference.
It really does, if we're talking about wellness. You know, if we were to ask, you know, what is wellness? You know, everybody has a different answer, and, you know, maybe if you're interested for the last couple of minutes, we can talk about wellness. Off the cuff, what is wellness?
I love the consideration of wellness, because for me it incorporates health, which to me is nutrition, and fitness, which is exercise, and it incorporates how we perform that for ourselves. So how do we self-treat? How do we self-medicate? And wellness is the balance between nutrition and fitness and exercise to a better you.
Mike, what about
Yeah,
you?
I really think of wellness as something that's an internal state. So it's how we feel about how we feel. So you can get all those tests and the lab work and you know, that can tell you whether you're healthy or sick, but your lab test can be completely clean, but you don't feel well. So that's
Exactly.
something that your internal state can change based on how you know, are functioning, how you perceive your life and your world. And you can feel more well from doing things like, you know, having a greater sense of empowerment in your physical body, whether it's through nutrition or exercise or balance, where you feel like now you're more stable, you're more safe. So you can have a greater sense of well-being just by, you know, addressing those things.
It's amazing in the medical profession today. Harvard University, a lot of the medical students, medical schools are incorporating some of the integrative modalities, nutrition, and looking at, you know, caffeine. We're looking at how fruits and vegetables, you know, affect cancer. I mean, so there's a shift. And I think as a medical physician, if we don't go align with that shift, then we're not doing our patients any good.
Right.
And I think that's really very important. Prayer, meditation, keeping aligned from a perspective of not only physical, emotional, but spiritual as well. I think all play into health, and that's important.
Last couple of comments
Yeah.
here. One was out, says, to the physical therapist, do you take all insurances? Do you need a prescription?
That's a great question, and we take almost every single insurance, and not all insurances require a prescription. So I wish I could have a clear cut for you, but if you go to our website, idealrehab.com, you'll be able to find which insurances we take, which is all insurances. I think we don't take one at the time, but otherwise it's every single one.
And then Cheryl Speen, Master Toe Reader, says, hey, Joe, it sounds like you and your mom have inherited thoughts. Carpal tunnel is anger, frustration regarding injustices in your life and not being able to hold on to it, no matter how hard you try.
That's interesting.
Cheryl's
A
awesome.
holistic approach.
That's right, different angle there.
We want to try to stay
Cheryl.
with
Thank you, Cheryl.
The reproducible, the objective findings, which is the carpal, the band that presses on that median nerve, producing symptoms, and that's important. Well, Joe, I think we're out of time. This has been a really great show. Thank you so much for being here.
Pleasure.
Great, thank you.
Thanks, Joe.
All right, another week. Tune in next Wednesday for DocTalk Radio, 1 o'clock, same time.
Why is it so hot in this room, yet cold in other rooms? There's got to be a solution.
You need to call the company for
I'm sorry, Dr. Borik. Here we go.
This concludes DocTalk Radio with Dr. Ann Borik. Till next time, I wish you health, wellness, and many blessings.
DocTalk Radio is brought to you by Gilbert Hospital and Florence and Anthem Hospitals. Topics discussed are for informational and not intended to substitute advice from your personal physician.